Thank you, Dr. Munir Khan, Dr. Vijay, Dr. Iqbal, Dr. Atri, and all of you for remembering us again and again to this beautiful place. And as Sarfraz had started, same way I am going to start with from Mir Khusro's. Agar firdos bare ruh zami ast, ami asto, ami asto, ami asto. Honestly, all my coronaries open up when I come to Srinagar, and we have had so many occasions of operating here in kidney hospital, in SCIMS, and in so many centers that I feel very, very happy from within, not from outside only, but from within. And wisdom is not to be obtained from textbooks, must be coined out of human experience, as Dr. Chirungu had also mentioned when he was chairing the session. And I bring greetings from Srinagar Hospital and Bhatia Global Hospital and Endosurgery Institute. When Dr. Atri phoned me that what should be your topic, and honestly, I told him few topics, he said no, no, no. Then I said, my answer is what not to do in hernia surgery. He says yes, yes, yes. So next 10 minutes, I am just going to tell you 11 lessons which I have learned in these many years of 4 decades. First is that if you are not good in anatomy, please do not do hernia repair. Unlearn, learn, and relearn. And believe me, all of us, when we started from bassining to Lichtenstein, to shoulders, to TAPP, TEP, ETAP, and so on and so forth, we have been the learners. We have never ever pretended to be the learneds. The day we become the learneds, we are doomed. And second lesson is, please believe within yourself, all recurrences are iatrogenic. Please do not blame the mesh. Please do not blame the patient tissues. Blame yourself. And please do not refer these recurrences to XYZ, or please do not let them go also. If, for example, you had operated a case, and if you had a recurrence, and if you are not interested in knowing your faults also, it is the biggest mistake you are doing for your own learning. So our thinking is, tissue is the main issue, all of us know that. If we respect the tissues, tissues will respect us. If we are extra-peritoneal, not extra-fascia transversalis, again and again I emphasize in all the workshops, please, God has created the planes only for the surgeons, not for anybody else. So please take care that we know our anatomy well, and then fat belongs to the anterior abdominal wall. And please remain extra-peritoneal, pre-peritoneal, and then only we will be able to deliver the best. And as I mentioned, please do not send your recurrences. If you send your recurrences somewhere else, then you will not be able to learn. For example, this is the patient in which laparoscopically mesh had been placed, and when the patient comes, you see that the lower margin of the mesh or the lower dissection had never ever been done. The mesh was placed, but never the dissection was done, and that is the cause of recurrence. So when we are doing TAPP or TEP or ETAP or any for that kind of surgery for inguinal hernia, we make it a point that the inferior margin of the mesh has to rest comfortably and at the level of the triangle of doom, base of the triangle of doom, and it is not getting folded in, it is not getting rolled in. Then only it will avoid any recurrences. And more important is, as was mentioned by Dr. Professor Chaube also, do the right surgery for the right patient at the right time. And this is very, very important. For example, if the patient is having infection and you start it, then you will have to explant the mesh and you will have to refer the patient to Dr. Azaz. So our thinking is that please do not oversell. Most of the times, most of us, are in a habit of overselling our technique. I was discussing with Dr. Sarfraz also, I did not want to say that peritoneal flap is the answer for everything. No, there are situations when you will come to know that the patient needs TAPP, TEP, ETAP, TAR, and so on and so forth. So one should always believe on that there are situations, there are complex hernias which will not go to anybody else unless you learn the techniques yourself. And for this, I will urge my younger colleagues, especially sitting at the back, please do not read these CT scan report. Most of us are in a habit of reading the CT scan report and then see the CT scan film. No, we have to learn, we have to unlearn and carry on learning by going to the CT scan, go into the details of this video. But again and again, we had seen the case yesterday, but our thinking is that please give lot of respect, and as Dr. Chaubey also mentioned, please visit those centers which are having large volumes of these kind of advanced surgeries and then get proctored and then start, rather than repenting and then causing damage to the patient. Our thinking is that there will be many situations in which, for example, you are not able to close the posterior peritoneum or the visceral sac. And then again and again in the back of mind, one should be very, very clear that I should not be responsible for causing a posterior dehiscence. And if the posterior dehiscence occurs, the peritoneum, the intestines can go within and that can cause damage. And now, again, as we were discussing, there is a role of TAR, transversus abdominis release, or there is no role of TAR. So this is again a gray zone. Please do not believe, carry on thinking, carry on learning, and then only adopt, because there are situations in which TAR will help. There are situations in which modified version of TAR will help. That means we do not cut the muscle, but we go into the pre-peritoneal, pre-transversalis fascia plane and then place in a larger size mesh and ultimately get the best possible result. Our outcome should be our guide, that we have to offer the best to the patient. And in this last decade, all of us have seen that the open complex hernias definitely had a role to play, but now the robotic is picking up very fast, especially in US also. So I would urge my younger colleagues once again, please go for robotic training, go yourself and train yourself for hernia, because robotic companies are also pushing the general surgeons to adopt this kind of technique and then give the best to the patient. And there is a role. For example, there will be some situations in which you are doing laparoscopy, you are not able to progress, so withdrawal is not a defeat. Withdrawal is not a defeat. You can always convert into a hybrid plane and then complete the surgery so that ultimately patient, the beneficiary, is not harmed at all. And as was again presented in mesh infection discussion also, please do not play with antibiotics. Please do not play with anti-tubercular treatment. Explant. If there is a mesh infection, explant the mesh early rather than delaying after so many world-class antibiotics. So it is always better to do your best. And again, we were in the era when we were crows and we had to put the pebble into the pot to get the quench thirst. Then came the era of using the straw, but now you see the pebble, the crow, which is absolutely modern, using the AI also, and it wants to quench its stress if you are ready to do it. If you are not ready to do it, then obviously you will carry on sitting and carry on thinking that where shall I get the pebbles, where shall I get the straw, and that will definitely is going to make a difference. And I must, in all humility, thank all my younger colleagues for remembering us here. And I remember when Mother Teresa also blessed us at the time of MBBS degree. We remember that 4 decades have passed, much blood has flown under the bridge. So why not carry on unlearning, learning and relearning? Thank you very much. Thank you. Any questions?
Thank you, Dr. Parveen Bhatia, for an excellent presentation. you are right in saying that an excellent surgeon and a good surgeon should know what to do and what not to do. Thank you.
So, any deliberations from the audience?
No less present. No questions.
We have already said what we wanted to say. Sir, you are always welcome. Please do grace us frequently and we'll learn what not to do. Thank you very much.
Thanks a lot. Thank you. Thanks a lot.